Welcome to this edition of Guts and Glory, the podcast explores the cutting edge innovations and science in HPB surgery. Today, I have a very learned member of our community, Professor Mahesh Goel, a good friend of mine, who's also the chief of hepatobiliary surgery at Tata Memorial Hospital Mumbai. Mahesh has been a pioneer and trailblazer regarding gallbladder cancer in terms of doing some groundbreaking research, innovations, and has generated substantial data which forms the basis of some of the paradigm shifts we see in the management of gallbladder cancer. Mahesh has, to his credit, several landmark publications in gallbladder cancer. And therefore, I have titled this podcast Science and Precision, and asking afterwards, have we cracked the gallbladder cancer challenge? Mahesh, welcome to this podcast. It's a delight for me, and I'm sure we'll have a very insightful and interesting conversations on gallbladder.
Thank you, sir. Thank you for such a kind introduction. And it's really a pleasure to be talking to you on gallbladder cancer.
So, Mahesh, perhaps you know, and also for the viewers, I've had two podcasts on gallbladder cancer. So you can see how much importance in India we are giving to gallbladder cancer. So one was on primarily incidental gallbladder cancer, and other was on advanced gallbladder cancer. But I felt that there are still so many layers that we can explore. So I bring you to the table to talk about two or three issues in gallbladder cancer. You know, we had that consensus meeting in Jaipur, I think 2 years back. We had a lot of debate on GBC. You had so much to contribute. So I want your viewpoint on this. So let me ask you upfront. Say I'm operating a gallbladder cancer. I've done a cholecystectomy. I get in 3 days the report saying there is a gallbladder cancer. And I call
Mhm.
you because you're a good friend of mine. And I say, Mahesh, what should I do now? So, what would you tell him? You want the patient immediately, you want to spend time, you want to call him after a certain period of time. What would be your advice?
What I would say is if a patient is detected as incidental gallbladder cancer, as you said, after 3 days, so I would be, if it is just 3 days, I would actually want the patient to come as early as possible so that if at all we can plan surgery. A 3-day exploration means patient is already explored, so we do not actually need to stage the patient except for probably a CT chest at that point of time. And if we have a confirmed diagnosis, I would not mind going in very early for the patient.
So, let me understand. So, you're saying if it is early enough, you operate. If it is about a week or so later, then you would operate when?
If we are going in after, say, a week or so, I think we all allow information to settle over a period of, say, 3 to 4 weeks before we go in, because we have to dissect at the level of POTA to do a complete lymphadenectomy. We don't want any surgical mishap to happen, and we want a complete clearance.
So, Mahesh, I keep on thinking about this timing of, and there are so many papers you people have written, and in your thing, I think it is about 8 to 10 weeks or something like that
Yes.
is the best time. So, let me put it like this, that is it by chance because these patients come to you, as you said, with a certain interval, it has panned out that this has come as a median time in which you are operating and patients have good results. If they had come early, this might have shifted to an earlier, window. Is it possible?
I absolutely agree with you. I mean, our mean time for a patient to present to us after an index cholecystectomy is almost around 6 to 7 weeks.
Yes,
And at that point of time, we definitely need to restage the patient, and that's
right.
where the role of pets can actually came in. But yes, if they are coming early enough, and in our paper also what we said that though we showed a marginal difference in terms of survival when we operated between 10 to 12 weeks of time, but that was only after we propensity score matched the patients. But what the conclusion, what we said in that paper was also that the surgery should be done as early as possible, actually.
I come to the other part. Now, we always talk of that surgery is required, right? We are very categorical about it.
Yes.
But we also know from the whole lot of data that when we operate, and if there is residual disease, the outcome is not good. If there is no disease, the outcome is good. So, are we operating just to do a much better staging?
So that was the second part of the conclusion of our paper on gallbladder cancer, in the revision surgery for gallbladder cancer.
Yes,
So that actually we concluded that for me, and that is my philosophy, and that is what I believe, is that revision surgery is at best the most accurate staging procedure for me. It allows us to stratify patient, that which patient should receive chemotherapy. So it's not the surgery, but the exact staging in terms, especially in terms of nodal staging, and it's the adjuvant therapy which actually has improved outcome. So the
right.
benefit of incidental is only when we are treating true incidental, which would be probably T1 disease or early T2 probably.
We get an accurate staging and then we plan the subsequent treatment. And
Yes.
it brings to the point again that if there are other modalities of better staging, say for example, you do a PET CT and you find a lighted up node or a small uptake in the bed of the liver, would you go in or would you then give chemo and then review and go in after a period of time?
In this patient, the disease is aggressive or at least a stage 3 disease. So, as per our definition and what we practice, we classify this patient as part of our locally advanced gallbladder cancer. And these are treated with chemotherapy first and then subjected to surgery and not upfront surgery. Because for me, the biology of this tumor is
Right.
quite aggressive.
Are there any
There's no bad
situations,
such.
say for example, like there is bile leak or things like that, would you have a different approach in that situation?
This is actually a very good question in the sense that we do face a situation where we know from the operative notes of a surgeon who has operated that there was a rupture of gallbladder or a bile leak. But
Right,
the tumor per se was not a high stage disease. If you, for example, if just a T2 tumor and
right,
he's done a cholecystectomy, but intraoperative bile leak has been documented. So
yes,
technically, it would upstage the disease. We would give chemotherapy first to test the biology of tumor, see how the patient is behaving. If the patient remains stable, there is no evidence of progression. Say after 3 to 4 cycle, which you usually use in neoadjuvant setting, I would again still go ahead and do a revision cholecystectomy in that group of that patient.
suppose I'm the patient and I was told I'm going in for cholecystectomy. You find a small lesion, you do a frozen, it's positive, and you say it is better to do a extended cholecystectomy. On the other hand, I, I'm still under anesthesia. You take consent from someone else. But what is the harm in coming back after 2 days with full discussion with me and doing a extended cholecystectomy?
So personally, I think there is no harm in coming back after 2 or 3 days after discussing clearly with patient. Only harm I would say is you are subjecting a patient to two anesthesia, two surgeries. So that is which would increase the cost as well as anesthesia and the trauma to the patient of taking two surgeries. But if
Yeah.
we have a high index of suspicion, then we should be cautious in our
Uh,
approach at the time of surgery. And that time we should do frozen. If positive, we'll go ahead with the radical surgery. See, it may not be bad to counsel before the first surgery
yeah.
itself that if this turns out to be, we'll go ahead and operate and clear the do the surgery as per gallbladder cancer surgery and make sure that everything is cleared
Yeah.
in one surgery.
It will be safe to presume that any time is good enough for re exploration. Certain scenarios merit extensive staging pre-op and or chemotherapy before, and we also agree that it is the best and most accurate staging procedure in incidental gallbladder cancer.
Yeah, absolutely. But sometimes we do get a patient, like for example, elderly patient, some 70 plus age, who has
Yes,
had a cholecystectomy and it's a T2 disease. And he
yes,
comes to me after, say, and this has happened a lot of time, come to me after at least 3, 4 months or 6 months after
yes,
index cholecystectomy. We do a staging, we don't find any evidence of disease.
yes,
So in such a
including PET.
situation, including pet, and he is
Yes,
not willing to undergo surgery. I would never say that it is a very rigid thing that it should be done
yes,
always. So
absolutely.
in that situation, you have to have a clinical judgment that okay, it is okay not to operate this patient. But
Yes.
as a rule, yes, for incidental gallbladder cancer, revision surgery should be done as early as possible after adequate staging whenever the patient presents to you. And it's probably the most accurate staging procedure which decides adjuvant treatment for the patient.
Mahesh, see, we all know. I mean, I was at SGPGI for so many years, and we used to look at so many advanced cancers and gallbladder cancer. Hardly we would be able to do a curative resection. I remember at that time because the diagnosis was delayed. My question is that we know the prognosis was bad, disease used to be advanced. Why did it take us so long to come to a strategy of neoadjuvant therapy in gallbladder cancer?
That even till 2010, there was now nothing much to offer in terms of chemotherapy in gallbladder cancer. Rather, I would say even in HPV malignancies. In GI malignancy itself, chemotherapy came much
Yeah.
later, and HPV much more later than everybody in colorectal also.
There's some prevailing thought among the peers that Tata has so much volume, so many patients come, they can't put them on the list. So it's a right place to start doing a trial for neoadjuvant chemotherapy. So tell me, Mahesh, I mean, I'm interested in this in terms of that how did this process, identification of subset of people, which chemotherapy to choose, how did this whole process come about? Because, it's very intriguing and interesting to see how it culminates into a randomized trial and then it sets the standards.
We have realized over a period of time in all solid cancers that surgery can do as much and nothing beyond. Being a local procedure, what how much radical you go, you
Yes,
can achieve or only up to a particular point of time or particular
yes,
percent, mainly because and that recognition or realization has to come that cancer is a systemic disease and local treatment alone cannot improve your outcomes beyond a certain point.
certain.
So that is first thing.
Absolutely. Yeah.
And secondly is I realized, I mean, when I came to Tata for to set up the whole gallbladder thing, I realized that for early gallbladder cancer, even simple cholecystectomy was achieving a cure rate of almost above 90%.
Yes.
That is so, and for metastatic disease, whatever we do, even today, we are struggling to go beyond even a year for with all metastatic gallbladder cancer.
True.
So only thing where we could probably make a difference is a group of patients which were not early and which were non-metastatic and which actually formed a major
Major
chunk of our
chunk.
because
Yes.
of 2010 we started experimenting actually with both neoadjuvant chemotherapy and
Chemo.
chemoradiation. We already had a US had a SWOG coming in which showed benefit of radiation in
Yeah.
adjuvant setting for Arthur's disease. And there were early reports coming for neoadjuvant chemotherapy and gemcitabine based chemotherapy already coming in. Bilcap came much later. So we did a pilot study first of neoadjuvant chemoradiation. Of it was a small study of around 28 patients, and we could show that we could improve survival in these locally advanced patients who were not
Right.
upfront resectable, and almost 50% of these patients could be operated. But we had a high morbidity in terms of bile leak in this group of patients.
Okay.
So that was one, and then we also experimented with neoadjuvant chemotherapy. When Dr. Bhavna Sirohi was there in Tata, we started giving neoadjuvant chemotherapy. We
Yeah.
published our first paper on neoadjuvant chemotherapy in 2014 and showed again survival benefit with neoadjuvant chemotherapy. So at that point of time, I realized that we have to actually go beyond that now and objectively define what we are treating. So we needed to have a objective criteria of treating these group of patients.
Yeah.
So that then in 2018 we published our seminal paper on neoadjuvant chemotherapy in gallbladder in
Mm.
HPB, where we actually defined locally advanced gallbladder cancer objectively.
Right.
We
That was
labeled
that
them as
classic paper. Yes.
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 We label them as objectively as TMH criteria, and introduce the term high risk gallbladder cancer to the world. The idea was that we wanted to identify the patients which were at high risk of local as well as distant failures. So
Right.
these were the patients which we thought would benefit by perioperative intervention to improve their outcomes. So we defined our TMH criteria objectively, pre-operatively criteria based on the T size, the ends, the node, the
Vascular
vessel
involvement.
involvement,
Yes.
and even incidental, the two scenario which I said, either they had a disease or they recurred early or had a node. This we treated almost 160 patients and then published, and we showed we gave perioperative chemotherapy in terms of neoadjuvant followed by adjuvant chemotherapy, total 6 cycles of gemcis, and showed that patient whom we could operate with curative intent, which were almost 40% of those patients which we could operate,
Okay.
had a survival had a superior overall survivor of almost 49 months versus 7 months for patient whom we could not operate or
Not.
who actually
That's
progress even on.
remarkable. Yeah, that's remarkable. That's, so
So
40% response rate or conversion rate, you
yes,
would say, right? And
yes.
with a significant benefit in survival in those 40%.
So then we launched our Polka GB trial, the first perioperative chemotherapy trial. So we had to answer that question, that which is better, chemotherapy, neoadjuvant chemoradiation versus neoadjuvant chemotherapy.
Right. Right.
So it was an ambitious trial. We tried to go multi-center, but it was very difficult. I mean, you would agree to that, to run a trial
Yes.
with chemo as well as radiation across India, where the radiation facilities are not uniform, to get people and also from people in north to give chemo and not operate patient whom they think can be operated is still at that point of time not very well accepted.
Yes. Yes. I understand.
So the accrual become very slow at a certain point of time, and because of that, we actually analyzed our data early, stratified the patient 1:1 into chemo radiation arm versus chemotherapy arm. So we gave 4 cycles of gemcis to chemotherapy arm, and we give radiation for 4 weeks and 2 cycles of chemotherapy. Idea was to equalize the time period
Yeah.
between the two arms.
Okay.
After that, after that, we again restage the patient because we knew there will still be patients who will progress despite chemo or chemo radiation. But we did not want to do another surgery in forms of staging lab, so we relied heavily on PET scan as a staging modality in the post neoadjuvant phase,
Okay. Okay.
just to
And
get a
anyways,
pause count.
those would be suitable for surgery, would have a diagnostic lab beforehand, right?
Yes, of
Or
course, of
staging
course.
lab. Yeah.
So staging lab was only done to rule out progression and metastatic disease.
Yeah.
And then after surgery, they were again subjected to the remaining cycles of chemotherapy, which we have predefined totally to be 6 cycles. So chemo arm received 2 more cycles and radiation arm received 4 more cycles to complete the whole protocol.
Same protocol.
So we
So
were,
have you analyzed the results? I thought ASCO, you presented in ASCO.
it
So
has
you
come up
want
for
to give
revision.
a little bit of this thing, that what are the response
Yes,
rates? Okay.
the chemo radiation arm did much better actually.
Yes.
So response rate was almost to the tune of 74% in the chemo radiation arm compared to 35% in the neoadjuvant in chemotherapy arm alone.
Wow.
The
That big a
statistic,
difference. Yeah.
yes, it was statistically significant and with a even a higher R0 resection rates compared to neoadjuvant chemotherapy. And when
Mhm.
we looked at survival, we had a significant survival advantage in neoadjuvant chemotherapy, chemo radiation arm. So almost to the tune of, I would say, 5 year survival was I think 29% for neoadjuvant chemoradiation arm versus 17% for chemotherapy arm alone, which
Five
was
years.
again statistically significant. But of course, even in this, we had a higher morbidity in neoadjuvant radiation arm
Oh, you did, because
in
that's
terms
what
of
you
bile
experienced
post
earlier. Yeah, yeah.
earlier also. It was much lesser, but it was still there.
Hmm.
So what we have concluded is, and that is been the next step. So radiation oncology group was ecstatic after they started propagating, saying that this, but I in APHPB also added a word of caution that we have to take this with a pinch of salt because finally we have to operate these patients. And if
Yes.
you really ask me, operating a post radiated POTA is much more difficult.
Yeah, I can imagine.
So
Yeah.
the whole thing comes into a white sheet. So
Right.
you need to have a high level of surgical expertise. So obviously we cannot propagate it as a thing which can be offered by to every patient or everywhere. It has to be done still in a highly specialized center, and we have to select our patients much better. In fact,
Right.
now we are doing another trial by the name of RUGB, which is radiation in unresectable gallbladder cancer. As a corollary to this trial,
Hmm.
I this thing will be much better. So those patients, we have still a large group of patients which are locally advanced, still non-metastatic, and we know looking at the disease that we will never be able to operate these patients.
Right, right,
What
right.
we
I
do,
know
they
it.
will never become resectable.
Yeah,
So
yeah.
very large liver infiltration, porta totally fused, artery totally encased by the neck gallbladder mass, which we know will never come up for surgery ever. We thought the radiation has definitely helped. It has helped in controlling the local disease. It has given giving us advantage, and this may still it will remain an important modality in the management of locally advanced. Probably the much more benefit we will get in patients whom we will probably never be able to offer surgery, but they remain non-metastatic. So in those group of patients, radiation has will probably show a much higher and much better treatment response.
What was the interval between radiation and chemotherapy and surgery?
So it is 3 months of neoadjuvant chemotherapy, and during the same period, we give radiation first, and
Yes.
then 2 cycles of chemotherapy. So by the time patient come up for surgery, it will be at least 4 weeks from radiation,
Oh,
and chemotherapy, of course, 3 weeks after radiation. So it will be more than four. It will be probably 6 weeks before after radiation that we will be operating these patients.
6 weeks. Yeah,
Yes,
because we now know some of these rectal trials that the
yes.
longer period is both beneficial in terms of the radiation effects being minimized and also getting the best outcome of radiation. This thing, but I think 6 to 8 weeks is a good enough time. Mahesh, let me ask you. I mean, what got you into surgery? What was your uh, you know, inspiration? Who shepherded you into surgery? Because I'm going to now ask about your innovations in surgical practice, but I want to hear that how did you get into surgery?
So I have only one guru. I would not even say teacher, I would say guru. That is Dr. Mathur. So I don't need to
SK Mathur,
tell
Dr.
anybody
SK.
about Dr. Mathur, Dr. SK Mathur. So
Yeah,
I was a MBBS student in KEM. As an MBBS student also, I was posted Dr. Mathur and was deeply impressed with his sense of discipline and searching for answers for questions which were not there. That time he was working on portal
total
hypertension and
hypertension. Yes,
developing the sclerotherapy
revascularization.
needed and all of
Yes.
things. So he is my inspiration, he's my guru, and he is the one who has inspired me to come to surgery actually. So and
Fantastic.
I've been
Fantastic. He's a great surgeon, great human being, and a fantastic
yes.
leader for HPB surgery. We all know that. So, surgery you did, you came to Tata. What about robotic surgery? How did you get into that? How did you train? Because you have made a tremendous impact on robotic surgery in gallbladder cancer, which I'm going to talk about. But how did you, it's interesting for everybody to know how you go about getting the training.
I'm not a laparoscopic surgeon. I was never trained to be a laparoscopic surgeon. And when Robo came to Tata first, we were one of the first centers in government setup to get a Robo, Da Vinci, in 2015.
Okay.
And we everybody wanted to operate. So I had no experience in laparoscopic surgery. I was not very fond of laparoscopic surgery, but Robo gave me a platform where we realized that as a open surgeon, it is much more easier to shift from open surgery to robotic surgery. You can actually mimic the steps of robotic surgery of open surgery in robotics. So
Yeah.
in laparoscopy, you have to somehow unlearn few things to actually become a robotic surgeon. And
Interesting.
since
Mm. Yeah.
So, I found it very easy. It appeared to me like a video game. And Since I was doing only hepatobiliary, more of hepatobiliary, I was not going to jump into liver upfront in robotics. So I decided that I'll mimic exactly the steps of open surgery in robotic and started. I had no other, there was no one to look above me or to follow someone in gallbladder cancer. Nobody was doing robotic gallbladder at that point of time. This is 2015-16. So I started slowly, selected my cases well. So I selected very early cases. I did not go into revision cholecystectomy because I knew the pota will be frozen. I was developing my skills on my own. So
Right.
slowly we started with early gallbladder cancer, and then scaled up as the experience improved. So I remember, I mean, as I was scaling up, this was World Congress in Brazil in 2016 or 17, I'm not sure. So where I presented my early work, and I was asked why you are not doing para-aortic nodal sampling, which is a
Mm.
standard of care. So I could have said that it's I'm only operating early gallbladder cancer, but then again I realized that this question will be asked again and again. So I went back,
I
added
did that, sir.
para-aortic nodal sampling, cauterized duodenum with my fourth retractor and R4, and added that to it. And by 2018, we had fairly standardized the process how we are going to do a robotic cholecystectomy, and then
Mahesh, I want to ask before you go into that. See, the general feeling is when you adopt a new technology or platform, you are by that time well versed and master in open surgery, right? Now, there is always a risk that when you get onto, there is a learning curve, there is a
yes.
compromise. So, how did you overcome and make sure that the quality is not compromised, the quality of surgery is not compromised when you're embarking on a new platform?
So two things I would say probably. One is that you should choose your early cases in your early part of your training very judiciously. Don't
Right.
try to do anything heroic, and those should be early cases where you know you will get away by doing a simple surgery, more of a simple surgery. So case selection is important, and secondly is not to have a surgical ego. So you should be always open to quickly converting to open if you find any difficulty, because patient safety is of paramount. When you're learning a new procedure, you don't want to be bogged down by any mishap which occurs, which will put your program back tremendously. So not to have
Also,
any
the
surgical
quality, you
ego.
don't want it to be compromised, right?
Yes.
Extent of
Yeah.
lymphatic.
For my first 50 cases, I did not do a revision cholecystectomy at all. I
Mm.
only did not even I did not even do a locally advanced case also. Most of my cases
Correct.
were probably T2 or early T3 with very few periportal nodes. So we selected our
Correct.
cases well. That been
Mm.
slow. And that should be the strategy if you are doing a procedure which is not nobody is there to guide you how to do that.
Yeah. Yeah. When you realize that there is a learning curve, what, according to you, should be the number for the learning curve that you say that beyond this, you should be able to do most cases after this?
So, yeah, I mean, we have not done any study. Very difficult to do such a study for gallbladder cancer. But I believe if you are a experienced open surgeon, probably I can just give a ballpark figure. What comes to my mind, probably you can do around 20-25 should be a good number for you to fairly standardize your surgical resection for gallbladder cancer. At beyond which point, probably you can think of scaling up your surgery in terms of doing more difficult cases.
Yeah. Yeah. Extended cholecystectomy or cholecystectomy, radical cholecystectomy for advanced gallbladder cancer or earlier for that matter, has certain steps and we replicate that robotically. Do you have any, suggestions, tips, or tricks for some of the steps to ensure, like, say, for example, lymphadenectomy uh, in robotic? That would be good for the viewers, good for me to know from you that what are those ways to do a good lymphadenectomy?
Yeah, so like all gallbladder surgery, we propagate that first step should be doing a paraotic nodal sampling. So
Yes.
I actually start my surgery by first thing is to uh, improve the vision in the porta or the area of porta. So I hitch up the falciform ligament so that the porta
Yeah.
is exposed better.
Yeah.
So first step would be to do a cauterization and do a paraotic nodal sampling. And when we cauterize duodenum, I realize the same chain continues at station 13 and goes to the 12P nodal chain, which defines your lateral margin of your bile duct. So
Yeah.
I invariably take out station 13 at the same time as 12P group of lymph node, and that defines my lateral border of the bile duct. One, and from there I then move on to the left side and define my so the idea is to define your anatomical structures well. If you are able to identify and delineate your anatomical structure, then lymphadenectomy becomes quite easy.
Yes.
So I kind of loop with vessel tape my common hepatic artery, the right and left hepatic artery, and the bile duct. So that way I'm able to protect them because margin of error is very less in robotics. It's just a 2-3 centimeter of area you're doing, and there is no haptic feedback also.
Yeah. Yeah.
Initially I was not doing Pringles, but I've realized in minimally invasive surgery, Pringle, when we have a full liver, we are not worried about injury caused by Pringle maneuver or porta clamping.
Yeah.
So, and then liver dissection becomes much easy.
Yeah. Like, do you do 4B5 or you do a wedge?
I always propagated wedge, and we published on our results showing that wedge is that wedge is actually just for margin and not anything more that.
Anatomical.
And
Yes.
I'm very happy. I mean, Dr. Shivendra Singh published probably the only true surgical RCT in gallbladder cancer. And I'm really proud of that. And though he used to do anatomical, but the trial also validated our concept that segment
Good
4B5 is
wedge.
not superior. It
Yes.
is just you have to, as it's in oncology, you need to just get a margin.
Do you use ICG during the extended cholecystectomy for identification of structures, liver?
For gall, I mean, I'm using ICG a lot now, but and now since of free in robotics, it is freely available with Firefly. It is not difficult to use ICG, but I have now not used it as a as a routine for identify biliary duct or structures in gallbladder surgery.
I want to go a step further. You have set benchmarks for a lot of these trials and work in gallbladder cancer. Where do you go from here? What's your next? You've done Polka GB. You said we need to do more trial. So, for clinical, where do you go? And are there anything else in the pipeline which will help us understand this disease much better?
So In clinical, I would say we have actually, so what we have realized that not all patient responds to neoadjuvant chemotherapy.
Right.
So there's a lot of group of patients which, despite neoadjuvant chemotherapy, would progress or despite chemotherapy. So we wanted to identify patients which will not respond to chemotherapy, which would be poor biology disease. So we
Right.
actually published a paper, pre-operative criteria, developed a nomogram, and assessed the clinical benefit response to chemotherapy to stratify patient who would actually respond and not respond to chemotherapy. That is
Oh,
one thing which I do. To one thing which I desperately want to do is to refine my criteria for locally advanced gallbladder cancer. So, like in pancreas, we need to now add more criteria. We have to get biological criteria in,
yes.
which is again very important. And I also need to externally validate these criteria
Yeah.
so that so they are more freely adopted by the world in gallbladder cancer. So, and third thing
Yeah.
probably is the flavor of of today, which is machine learning and AI. So we struggle a lot with patients of chronic cholecystitis, xantho, differentiating between
Yeah.
whether there is malignancy or no. Probably machine learning tools will help us. Dr. Pankaj Gupta is doing a lot of work in AI and machine learning. He defined GB
Chandrika,
rats.
PGI
Yeah,
Chandrika.
yeah,
Yeah.
we may get to a area time where we'll able to differentiate much more better, and
Yeah. I think
so
that
it,
is one area where AI, I'm sure, is going to have an
yes.
impact in early detection. So look into the crystal ball, yeah, and see what are you looking at in the near distant future, which will have an impact on how we treat gallbladder cancer.
uh, Molecular profiling, we are already seeing the effect of that. I mean, we have seen in my practice also patients who are PDL1 positive, which we had almost written off as that these will never become operable.
Right.
The way we are seeing response, and we have actually operated 2 3 patients after durvalumab
Durvalumab.
were responded brilliantly. So I think, and we a lot of work is being done in molecular. We need to have biomarkers to identify patients who are going to respond. A lot of work is anyway going on in the world in that field. Hopefully, we'll develop more and more immunotherapy drugs, markers, which will help stratify these patients and select patient better. Because till some time back, we were lost in knowing that which patient will respond and which will not respond.
Yeah.
So
Yeah.
probably, and if you talk about crystal ball, so I would say, like in breast cancer now, it is almost becoming that there in some few years surgery may become obsolete even in breast cancer.
Yeah.
So similarly thing happening in colorectal also with TNT approach, and in colon surgery as well.
Yeah.
So I think surgery will
Yeah.
not become obsolete, but will be selecting patients better
Better.
and with better biology, and probably then only the outcome will
So,
improve further.
because you mentioned one of these things, Professor S.P. Kaushik used to draw a parallel between how we were treating breast cancer a couple of decades ago with mastectomy and radiation. He said, why can't we do the same thing for gallbladder cancer, cholecystectomy and radiation? As a matter of fact, we started doing that SGPG, and now you say radiation is better. So, there's something to look back and say that there was a thought there.
Yeah, so I think in oncology, everything comes up full circle. We start with more radical procedure,
Yeah,
then get certain things which allow us to become more and more conservative, organ preservation, and
yeah,
then we move on from there. So
correct. Yeah,
it's a cycle which every solid tumor goes through.
yeah. Well, Mahesh, it's been a pleasure. Thank you very much. It's a fantastic conversation we have had around these three issues, and I've learned a lot. All the best to you for doing more research in this, and hopefully, we'll have a much defined paradigm for treatment of gallbladder cancer. Thank you very much.
Thank you, sir. It's my honor and privilege to have spoken to you. But last word before I sign off is that I would like to say this is not my work alone, but of a dedicated team which we have been able to build at Tata. And the credit goes to my colleague surgeon Shraddha, medical oncologist Vikas, Anand, and radiation team led by Reena engineer. And it's only in a MDT setting when you have everything that you can
Yes.
able to do trials, answer question, and that's how you can move forward. So thank you very
Fantastic.
much.
Thank you. Thank you.
Thank you.